Good morning, everyone. I'm Dr. Vinod Arora, Associate Professor, Department of Hepatology. I'll be talking in brief about understanding the destabilizing factor in the hemostasis during the acute decompensation of cirrhosis. Patients with acute decompensation of cirrhosis are in a precarious hemostatic equilibrium. Presence of acute kidney injury, underlying bacterial infection, sepsis, or progression from acute decompensation to ACLF increases the risk of bleeding. There is a complex hypo and hypercoagulable state which is present in these kind of patients and which we'll be discussing in brief today. What is hemostasis? Hemostasis is a physiological process which stops bleeding at a site of injury while maintaining the normal blood flow elsewhere in the circulation. So, discussing a brief about the coagulation in a healthy individual, it is divided into three stages: primary, secondary, and tertiary. At the primary, there is a breach in the endothelium, and the platelet, they go to the site of the injury, and with the help of von Willebrand factor and the simultaneous aggregation of the platelet, they form a plaque which is basically stabilized later by the fibrin. This basically shows the endothelium, smooth muscle fibroblasts. They are WBC which are initially marginated towards the lining of the endothelium and come to the center, and the platelet and the fibrin clot breaches the site of the injury. And these are the intrinsic and the extrinsic coagulation pathway which are activated. They include two parts: extrinsic, which is formed by the PT, which is activated by the tissue factor, which is exposed by the injury to the endothelium, activating the factor 7. Then the tissue factor and the factor 7, they form a complex, which in turn activates the factor 10. The active factor 10 and 5A, in the presence of calcium, they activate factor 2 to form thrombin, and this basically initiates the clotting phase, and which is then propagated, and multiple fibrin polymers and cross-linked fibrin polymers are formed, forming the clot. Similarly, there is an extrinsic pathway which is basically activated by the high molecular weight kallikrein, which activates factor 12, which in turn activates the factor 11 and then factor 9, ultimately leading to a combination of a complex between factor 9 and factor 8, which in turn activates the factor 10, and factor 10 and 5A in the presence of calcium activate factor 2, and multiple fibrin and polymers are formed via the thrombin. This basically shows a similar thing, and there are two phases. Initially, there is a phase of initiation followed by a phase of propagation, and it is initiated by the exposure of the endothelium, and in turn exposing the tissue factor, which activating the factor 7, activating the complex between the factor 10 and 5, and this basically leads to the activation of the factor 2, leading to the formation of the thrombin and the fibrin polymers. Similarly, in the extrinsic pathway, there's basically a factor 9 and factor 8A complex activates the factor 5 and factor 10A complex, leading to the formation of the thrombin polymers. So there's a rebalanced hemostasis in the liver disease. In a healthy adult, there's a state of homeostasis which is maintained. And however, in the cirrhosis, it is dynamic and precarious balance which is maintained. And there's oscillation between the bleeding and the thrombosis. Whenever there is a clinical event like SCC or endothelial dysfunction, it promotes thrombosis. However, in presence of some infection, bacterial sepsis, or acute kidney injury, it predisposes to bleeding. So the patient is oscillating between these, is maintaining a balance which is very, very narrow, and oscillating between a state of thrombosis and the bleeding. So bleeding is common in liver disease, and it's multifactorial, and it can be because of the liver failure, kidney failure, presence of low hemoglobin, sepsis, portal hypertensive bleed, which can be seen in patients with cirrhosis. Spontaneous bleeding is usually uncommon. Active bleeding can be from vascular tissue or following invasive procedure. The risk of peri-procedure bleeding can be difficult to assess in individual patients, and coagulation abnormality worsen with the deterioration of the liver function. This basically shows the balance which is between the anticoagulants and the procoagulants in patients with cirrhosis. It's like an elephant standing on single limb. It is rebalanced but very precarious and with a poor reserve. What causes this coagulation imbalance in the liver? This can be explained by this cartoon. There's dysfunction of the hepatic parenchyma leading to the decrease in the anticoagulant and both procoagulant protein. There's a dysfibrinogenemia. There's a systemic inflammation via the necrotic liver tissue causing endotoxemia, systemic inflammation, and increased endothelial activation and production of factor VIII, tissue plasminogen activator, and wall-valent factor. There's a decreased hepatic clearance of these compounds leading to the increase in factor VIII, factor VII, wall-valent factor, and tissue plasminogen activator. There's splenomegaly causing platelet sequestration and platelet destruction. Then increase in the intrahepatic resistance flow, reduced flow venous stasis, causing promoting this plankton vein thrombosis, increased venous thromboembolism via stellate cell injury, causing increased hepatic fibrosis. This basically predisposed to bleeding sequelae also, leading to varicose bleeding, hematomas, epistaxis, and procedure-related bleeding. So there are hemostatic alteration which are noted in liver diseases. There are factors which are promoting clotting. There's increased von Willebrand factor, decrease in plasminogen, increase and decrease in protein C and antithrombin, and increase in the factor VIII. Then there are factor promoting bleeding. There are dysfunctional or platelet functional defect or thrombocytopenia, decrease in the clotting factor production by the liver, increase in the tissue plasminogen activator and inhibitors and of the fibrinolysis are decreased. So coming to each step, which is disbalanced in the cirrhotic patients. First is primary hemostasis, that is the formation of the platelet plug. The anti-hemostatic mechanism that are present in cirrhosis are thrombocytopenia and platelet dysfunction. However, the pro-hemostatic mechanism are high von Willebrand factor and low Adams 13, which predispose to the pro-hemostatic state. The quantitative platelet effects are commonly seen in chronic liver disease. Platelet-derived microparticle are seen as having procoagulant effect and role in systemic inflammation. Adequate thrombin generation, that is dependent upon factor V, von Willebrand factor, factor VIII, fibrinogen, calcium, and ADP. And 50 to 60,000 of platelet counts is enough for the generation of this primary hemostasis. The changes in primary hemostasis, thrombocytopenia is common in patients with cirrhosis. The functionality of platelets is unclear. Platelet function tests are difficult in thrombocytopenic function. The thrombocytopenia, as I told, is common. There is elevation in the von Willebrand factor. However, it is functionally impaired as the stage of the child A to C. There is an increase in the von Willebrand factor. However, there is a decrease in the viscosity aggregation assay, which basically measures the quantitative function of the von Willebrand factor. This basically shows that there is an increase in the von Willebrand factor and which compensate for the low platelet count in patients with cirrhosis in the primary hemostasis. Coming on to secondary hemostasis, this low procoagulant factor and low fibrinogen and dysfibrinogenemia are they predisposed to bleeding. However, they are compensated by a high factor VIII, low in anticoagulant proteins, and impaired in thrombin factor, plasminogen inhibitor pathway is impaired. These are the changes which take place in the part of the secondary hemostasis. The factor 2 is decreased. However, there is an elevation in the factor VIII, which is a procoagulant, which is noted in patient as the stage progresses from child A to child C. Similarly, there is a decline in the protein C, which is noted as the stage of the cirrhosis increases. So the balance between, there's an increase in the factor VIII and there's a decrease in the protein C. So the overall state is tilted towards the procoagulant state. However, the disbalance can be exacerbated by the presence of a kidney injury, bacterial infection, sepsis, or decompensation in form of ascites or ACLF. So there are changes which are also seen in the tertiary pathway. These are the factor promoting the bleeding. There is low antiplasmin, there is low thrombin activatable fibrinolysis inhibitor, there is high tissue plasminogen activator. They basically promote towards the bleeding, and low plasminogen level and high plasminogen activator inhibitor 1, they predispose to the clotting. So there is a concomitant decrease in the pro and the antifibrinolytic factor, which are basically seen in the patient with the cirrhosis, and the hemostasis is maintained between the pro and the antifibrinolytic factors in cirrhosis. The generation of thrombin in presence of the thrombomodulin is preserved in patient with cirrhosis. So to summarize, thrombocytopenia and platelet defects are common in patients with cirrhosis. The low level of coagulation proteins or inhibitors are noted in patients with cirrhosis. There's low level of fibrinolytic protein. There are functional changes which are noted in the hemostatic protein, and there are high von Willebrand factor, factor 8, a tissue plasminogen activator, and a plasminogen activator inhibitor 1, which maintain a hemostatic balance in the patient with cirrhosis. Coming on to the next topic, that is the hemostatic alteration which are seen in patients with acute decompensation. The acute renal dysfunction is the most common organ failure, which basically defines the acute decompensation, and it is the commonest complication basically seen in patients with decompensated cirrhosis, and approximately 30% of the hospitalized patients present with acute kidney injury. It increases the risk of procedure-related bleeding. This was basically post-paracentesis hemoperitoneum. This was a study published in 2020, which basically shows presence of AKI was the most important, was the only predictor of post-paracentesis hemoperitoneum in patients with cirrhosis undergoing a large volume paracentesis. So the acute kidney injury in decompensated cirrhosis associated with both hypocoagulable and hypercoagulable features. There is lower platelet aggregation and secretion predisposing to increased bleeding. There is an increase in factor 8 and decrease in protein C, protein S, and antithrombin factor. And there is a decrease in factor 13, which help in the stabilization of the clot, which is predisposing to increased bleeding tendency in patient with AKI and acute decompensation of cirrhosis. And there is an increase in plasmin and antiplasmin complex, indicating in hyperfibrinolysis state. This basically shows that in presence of AKI, the INR, platelets, fibrinogen, von Willebrand factor, protein C, factor 8, they are comparable in patients with cirrhosis and with AKI and cirrhosis with no AKI. However, and the thrombin generation was also comparable between the patient who were having AKI and no AKI in the presence of thrombomodulin. The only distinguishing feature between the patient who are having AKI in decompensated cirrhosis is low factor 13 level. They basically have a poor clot stabilization, and they have an increased risk of bleeding. Similarly, platelets are also activated in AKI. These are the platelet-related microvesicles which are activated in the presence of AKI, and platelet dysfunction is noted, which predisposes to increased bleeding in patients with having AKI with decompensated cirrhosis. So to summarize, the changes which take place in AKI and this coagulation, they're in the primary, secondary and tertiary level, there is reversible platelet dysfunction affecting both the aggregation and the secretion. However, there is no change in von Willebrand factor, and this contributes to bleeding. There is increased factor 8 and decrease in protein C, protein S, and antithrombin, and there is increase in thrombin activation time, but there is no effect in the thrombin production. This basically contributes to thrombosis. There is lower factor 13 level, which helps in stabilization of the clot. There is lower plasminogen alpha-2 antiplasmin and higher tissue plasminogen activator, and lower thrombin activatable fibrinolysis inhibitor, which contributes to bleeding. Coming on to the second complication, which are the bacterial infection, which can be seen in up to 32 to 40% of the hospitalized patient at the time of admission or during the hospitalization. Bacterial infection and endotoxemia has been shown with the failure to control variceal bleed, increased risk of early rebleeding, reduction in the peripheral vascular resistance, worsening of the liver function, and abnormalities of the coagulation. Whenever there is an inflammation, infection, it basically drives the inflammation, which basically predisposes to a pro-inflammatory, procoagulant, and antifibrinolytic state. Via increase in factor VIII thromboxane A2, increase in von Willebrand factor, tissue plasminogen activator inhibitor, and tissue factor. And there is decrease in prostacyclin, increase in glycosamine glycan, which basically decreases tilted towards say the pro-inflammatory state. So what are the effects which are seen? The effect of the bacterial infection on the platelet. Moderate thrombocytopenia is most commonly seen in patient with bacterial infection and acute decompensation of the liver. Platelet aggregation is impacted in patient with decompensated cirrhosis and bacterial infection. The von Willebrand factor and riscocetin assay are comparable in patient with infection and no infection. Similarly, in patient who are having infection, there is a decrease in factor 7, and however factor 8 is comparable. There is a decrease in protein C, protein S, and antithrombin, which is noted. Similarly, there is an increase in plasminogen and tissue plasminogen activator. So there is a decrease in tissue in plasminogen and tissue plasminogen activator, which is seen in patients with infection. This basically shows how the platelet aggregation is important in patient with sepsis. Platelet aggregation rate of less than equal to 35.8 has been shown as a predictor of mortality. In patients who are having a normal lactate, platelet aggregation of less than 33 has been shown as a predictor of mortality irrespective of the lactate. This basically why the platelet aggregation rate, the 28-day mortality area under the curve was 0.81, and cutoff value of 35.8 for platelet aggregation rate has a sensitivity of 86 and specificity of 66%. And after adjusting for platelet aggregation rate is an independent predictor for probability of 28-day mortality. Similarly, this basically shows the changes in the platelet mitochondria which are seen in patients with sepsis. The ATP generation is hampered. There is a decrease in the mitochondrial matrix polarization index, which is seen in patient with non-survivor as compared to the survivor. This basically shows the electron micrograph image of the patient, of the platelet of the patient. There's a increased vacuolization of the mitochondria, and they are inflamed. This was the study assaying the change in the coagulation factor, which are seen in patient with sepsis and without sepsis in alcoholic hepatitis. There was a dynamics change which was studied from day 0 to day 7 in factor 8 protein C, von Willebrand factor, tissue plasminogen activator, and plasminogen inhibitor. There was a significant elevation which was in factor 8, which was noted in patient with cirrhosis, which was maintained from day 0 to day 7. Similarly, protein C was lower in patient with sepsis, and von Willebrand factor initially was high in patient with sepsis, with day 7 it gradually reaches the normal level. Similarly, the tissue plasminogen activator, it basically is higher at the baseline and remains the same at the day 7. And plasminogen activator inhibitor is higher, however no significant changes were noted as compared to the baseline. So in sepsis there was an increase in factor 8 which was noted, and there's a decrease in protein C and increase in von Willebrand factor initially which was noted, which came down to the baseline at day 7. Similarly, increase in tissue plasminogen activator which was noted, and which was comparable at day 7. So this basically shows the fibrinolytic status in the critically ill patient in cirrhosis, which was stratified by the septic status. In patient who were having sepsis, there was an increase in the clot lysis time. This basically, and similarly in the non-survivor, there was an increase in the clot lysis time. This basically depicts there's an increase in the clot lysis time, which is noted in patients with critically ill cirrhosis with sepsis and patient who are having poor survivor. This basically shows there's a state of hypofibrinolysis, and this basically predisposes to the formation of the microthrombi and organ dysfunction and ultimately mortality in patients with decompensated cirrhosis and sepsis. So to summarize, the changes which are taking place in the in presence of bacterial infection in primary hemostasis, there is a reduced whole blood platelet aggregation, there's a non-significant increase in von Willebrand factor and non-significant reduction in ADAMS 13, which predisposes to bleeding. There's reduced level of this anticoagulant protein CS antithrombin, and there is a heparin-like effect impairing the clot formation and stability, and this basically contributes to both bleeding and thrombosis. There is lower plasminogen level, higher tissue plasminogen activator. However, there is an increased clot lysis time indicating of hyperfibrinolysis, and this basically predisposed to bleeding. So now we'll move towards the ACLF part, acute decompensation, progressing to ACLF. There's a distinguishing feature which was noted between the ACLF and the patient who are having acute decompensation. There's an increased clotting time, increased clot formation time, and decreased velocity of clot formation, which were noted in patients with ACLF and as compared to the acute decompensation. And this progress, there's an increase in the clot formation time, clotting time alpha, and decrease in alpha angle, which was noted in patient with ACLF. However, in acute decompensation, there was a tendency to stabilize or return or coming back to normal, which was noted in patient with acute decompensation from baseline to day 7. Similarly, in time, similar changes were noted in ACLF as compared to acute decompensation. The hypocoagulable profile, which is basically defined as more than equal to 3 different parameters which are noted in X-time or N-time, was more common in ACLF, was seen in approximately 1/3 of the patient as compared to the acute decompensation. Standard conventional tests were also more hampered in patients with ACLF as compared to acute decompensation. However, the level of platelets and fibrinogen was comparable between ACLF and acute decompensation. So how the coagulation differs between the ACLF and acute decompensation? The patient with ACLF, they have more hypocoagulable state as compared to acute decompensation. They have prolonged time to initial fibrin formation or increased clot formation time. They have a decrease in maximum clot firmness in ACLF patient, which was noted, and the thromboelastography parameters worsened in ACLF, but they improved in patients with acute decompensation. Hypocoagulable state was increased in ACLF either at admission or during hospitalization, and it basically correlated with systemic inflammation and higher 28-day and 90-day mortality, and not with the transfusion requirement. And a prolonged time to initial fibrin formation, that is extrinsic TSA more than 80 seconds, was a predictor of mortality. This basically shows how the coagulation failure in patients with sepsis in ACLF, and it was basically patients were divided into 3 groups: patient with SIRS or no sepsis, subject who developed SIRS, then sepsis, and subject with de novo sepsis without any SIRS. And the hypocoagulability was defined on R angle, R time, K time angle, and maximum amplitude. The SIRS was noted in up to 40% of the patient, in sepsis in up to 56% of the patient. Hypocoagulable state was a predictor of bleeding and mortality, and bleeding was noted in 67% of this study population, and severe was noted in 24% of the population. So the hypocoagulable state was common in ACLF patient, and lysis was higher at all point in the sepsis group. So so how to predict the major bleeding in ICU patient with cirrhosis using the standard conventional test. This was a paper published in Hepatology in 2016, basically which showed the fibrinogen less than 60, platelet less than 30,000, APTT more than 100 seconds, basically had a higher specificity in predicting bleeding with lower sensitivity. How this plasma level of fibrinolytic proteins vary in acute decompensation and ACLF patients. The clot lysis time was comparable in acute decompensation to control. However, it was higher in ACLF patient. Similarly, that tissue plasminogen activator inhibitor was basically higher in the acute decompensation and ACLF as compared to the controls. Similarly, the ACLF patient have a lower plasminogen level, and they have a lower this fibrinolysis inhibitor protein. So to summarize the changes which take place in coagulation in ACLF patient, there's no data on the platelet activation and function. However, increased level of von Willebrand factor and reduced level of Adams-13, which is noted, which may contribute to bleeding. There's reduced level of the anticoagulant protein, which is noted. There's lower fibrinogen level and lower thrombomodulin modified enhanced potential and peak height, lower clot formation, which predisposed to bleeding. There is a lower plasminogen level, there is lower thrombin activatable fibrinolysis inhibitor and lower factor 13, and a longer clot lysis time indicated of hypofibrinolysis, and increased lysis, which is noted on TEC, indicative of hyperfibrinolysis. So it may contribute both to bleeding and thrombosis. So decompensation in form of ascites can also predispose to a state of fibrinolysis. This was a study which was recently published, basically which showed there is an enhanced tissue factor related extracellular vesicle which are available in which are present in the ascitic fluid, and there is no activation of the rest of the clotting factor as compared to the plasma, and there's a gradual increase in the D-dimer value, which was noted as the grade of the ascites progressed. So this basically predisposed to a state of DIC and hyperfibrinolysis in patient as the ascites progress or the grade of the ascites worsens. So there's a dynamic coagulation profile changes which is seen in patient with cirrhosis and ACLF and acute and chronic liver failure. There's a state of neutrophil activation and endothelial dysfunction and release of the inflammatory cytokines, and there's a decrease in the procoagulant factors, defect in the fibrinogen or dysfibrinogenemia. There's low antiplasmin levels and tissue plasminogen activator and inhibitor of plasminogen activator is high. This basically predisposed to bleeding, and there's endothelial dysfunction, release of the heparinoids, and elevated tissue factor 8, and von Willebrand factor, decrease in the anticoagulant protein, and decreased plasminogen, which promotes thrombosis. So these are the so we have to basically stratify the patient with decompensated cirrhosis on the presence of acute kidney injury, bleeding, bacterial infection, acute decompensation progressing to ACLF, prior history of bleeding, whether the patient is undergoing a low or high risk procedure, presence of thrombocytopenia or alteration in the platelet dysfunction, and assessing the rebalancing hemostasis in decompensated cirrhosis, and assessing the bleeding risk in individual patients. So a comprehensive risk stratification should taken into the consideration to identify and stabilize the destabilizing factor in the hemostasis, and coagulation failure basically marks the onset and can characterize the severity of hepatic decompensation, and basically it is the inflammation which is related to coagulation failure and evolution to ACLF, and sepsis, kidney injury, They are the main precipitant of coagulation failure and decompensated cirrhosis. In resource-limited setting, optimizing platelet to 50,000 and fibrinogen to 120 prior to the procedure may help in reducing the bleeding risk. Thank you.